and we'll take a 20 to be back at 12. Yes. All right. So you'll see in your box that you have right transurethral needle ablation, tune-up, microwave therapy, a stent, vaporization, incision. The one that you need to know is on the right side. Prostatectomy, open or laparoscopic. It's like what it sounds like. Okay, they just open you up and want to remove this. Not the preferred. The next one is TURP, transurethral resection of the prostate. Most common surgical procedure for BPH. Uses a resectoscope, trim the excess prostatic tissue away to enlarge the passageway of the urethra through the prostate gland. So again, they just take some of it out. Since some of the prostate tissue is removed, the prostate can potentially continue to grow. Okay, potential complications are trauma, bleeding, infection, and recurrence. Pre-op, what's our concern pre-op? Informed consent. Okay, and the big thing is post-op. This post-op care is, you see how small it is? Just this little section, okay? And for the male repro, if I was to ask you 10 questions, 8 of them would probably come out of that little section, okay? TURP is what's mainly asked about in all of male repro, and it's specifically that post-op care. What are we gonna do to manage it, okay? So, monitor vitals and urinary output. So we talked about the importance of urinary output. Give them fluids, is a good one, okay, to continue that flow. Increase fluids. Monitor for bleeding. Now this is the important one to kind of understand. Persistent bright red bleeding, unresponsive to increase in CBI and traction of the category, or reduced hemoglobin levels. This will all indicate too much bleeding. You report this to the provider. So let's go a little bit over that, because then it'll continue down below. Okay, but basically, let's continue to read actually, and then I'll put out the points for you. So, you'll assist the client to ambulate as soon as possible. This is called prevent DVT, right? Give them their pain meds, antibiotics, and stool softeners. So there's 4 lists of meds there. And these are for right pain, the spasms, antibiotics for infection, and it's not that they have one, but to prevent it, and a stool softener to put less pressure and strain against the prostate. Okay? Continuous bladder irrigation. Following TURP, the client can have placement of an indwelling three-way catheter, which will drain the urine and allow for CBI with normal saline. This will keep the catheter patent, like I explained to you, to prevent the clots from blocking the catheter. The catheter has a large balloon, 30 to 45 milliliters. Taped tightly to the client's abdomen or thigh. That's another thing to know. People ask when they have a catheter, or any in general, because they're used to seeing them to the leg. You can tape them to the lower abdomen, in case you didn't know, like right here. This will prevent it from pulling, okay? And I've seen people get that wrong. They're like, why do you think to tape it to their abdomen? Why don't you tape it to their abdomen? So yeah, you can tape it to the abdomen, okay? Creating traction so that the balloon will apply firm pressure to the prostatic fossa to prevent bleeding. This makes the client feel a continuous need to urinate. Instruct the client not to void around the catheter, as this will cause spasms. The rate of the CBI is adjusted to keep the irrigation pink or lighter. Okay, for example, if bright red or ketchup appearing bleeding with clots is observed, notify the provider and you may need to increase the CBI rate. Monitor for urinary output. Okay, record the amount of irrigation solution instilled and the amount of return. The difference equals urinary output. If obstructed, okay, the first thing you do is check for kinks, turn off the CBI, and irrigate Using aseptic, that means surgical sterility, right? With 50 mLs of irrigation using a large piston syringe. Contact the provider if you're unable to dislodge the clot. Catheter removal, you will monitor for urinary output. The first P's will be uncomfortable, red in color, and contain clots. It will turn to amber 2 to 3 days. Instruct the client that the expected output is 150 to 200 every 3 to 4 hours. The client should notify the provider if unable to void. A bunch of good key points. Let's start with the number 1. As continuous bladder irrigation is happening, the P, or the return, should be pink. Okay? If it is red or ketchup-like, meaning like thick, viscous, very red, this is a no. So what's the first thing you do if this happens? I don't know what you guys said, but probably no. You will increase the CBI. Don't overthink it. You will increase the CBI. You will increase the rate, okay, so it can filter out faster. Okay? In real life, you probably call. In real life, there's probably orders. What's your max rate? So you'll continue to increase it, okay? Until it turns pink, okay? If it does not respond to increased CBI, it is still red, ketchup-like, you're passing large clots, you will let the provider know. Now, if there's no flow, right? Nothing is happening, you're not really seeing flow, it's blocked, what's the first thing you do?
Reposition.
Check for kinks. Reposition. Flush. And it says right there, 50 milliliter piston syringe. Notify provider if you're unable to dislodge it. Yes? It's a big balloon. It pushes on the prostatic fossa. That's like where it's at, like the opening. This causes the urge to urinate. This is normal. However, do not urinate. The catheter is doing that for them. If they do, they'll cause spasms and more complications. They should not urinate around the catheter. Don't tell them to try to urinate. So if they tell you where the balloon is pressing, prostatic fossa, right? It should be tight against the prostatic fossa. It should be like flush, like that. Okay? And when it's pushing on the fossa, okay, it'll make you feel like you need to pee. Don't pee. People do this without this. Even with Foley's, they feel, especially if they're like mostly well, but you did it for acute retention, they'll tell you like, I need a pee. You gotta remind me, you have a catheter. It's gonna pee for you. Okay? Do not urinate. Take your medications. One for pain, one for spasms, prevent infection, and stool softener. Understand the purpose of each one. Okay? If it stays red or ketchup-like, or you're passing large clots, call the provider. Small clots are okay. Yes.
So you're saying, so usually it's not like a range?
In real life, yeah. For things like that, if he's smart, he'll leave a range. If he's dumb but thinks he's smart, he'll leave a range without an order, and you not wanting to violate the order and legality, will call him, and then he'll be mad that you called him instead of just raising it. Yeah? Yeah. And since I had to explain to them, you should have left an order because XYZ is how we do it here. He's like, well, I don't even know how to use a computer system here. Well, sounds like a problem, doctor. You should learn how to use a computer, maybe. I was about to slap him. I'll tell you why. Okay? The lady was bleeding out of her incision. He did an abdominal incision, he removed, I forgot what the hell, okay? And it started bleeding a bit, right? And it started bleeding more. And so like, we're like putting stuff on it now. First day post-op, she's less than 24 hours. I didn't want to remove the dressing or replace it, because most doctors on this floor don't want that. They do the first dressing. We can reinforce. So I reinforced it and it started leaking through the reinforcement. So she's bleeding more. And I'm calling this dude, and he's not answering. Finally he picks up and I tell him, he's like, check like blah, blah, right, to see where it's bleeding. It's like, it's from the dressing and it's leaking through. Eventually the church nurse calls him back, and then he comes. And he tells me, he's like trying to explain bleeding. He's like, well, obviously, he's like, she's bleeding because she has an incision. And he's like, so, like, here's how it works. Like, if I cut you, like, you would bleed, and you would need to apply pressure. And I was like, dog, oh my God. He's talking down to me so bad, bro. And I'm like, I said, I get that. And then I explained to him what I told him. I said, you left no orders. I said, and how it works here is, without it, we don't move. Especially when all the doctors here don't like their dressings changed. He's like, they do things like that? I said, they're anal about it. I said, I know you're new. He's a new doctor. I said, I know you're new here. I said, so if you want to, we will learn, and you don't care. I don't mind removing the dressing and packing it again. And unless a stitch comes out, we'll call you. I'm like, but if I don't know you, I said, so how would I know to do that? He's like, no. He's like, I get it. Like, I don't know the computer system here, so I didn't put in orders. I said, I get that. I said, do you want me to put in orders for you? I said, because at least if you say it to me over the phone, I'll put them in for you. And he's like, yeah, that can work. And he gave me like a barrage of things.
Sounds like a win-win situation.
I lose patience really fast with these results. All right. Lastly, last point. When they remove the catheter, what will you see initially? Small clots, blood tinged, right? Uncomfortable, right? Like a little bit of pain. And then 2 to 3 days, what do we see? Amber. Do not strain. Do not strain or sexual intercourse up to 6 weeks. Up to 6 weeks.
That's crazy. No, not November.
Time for break?
A lot of you have gone longer than this right now, and not because of a turf. Don't lie.
It's a choice.
Standing like this at the club. I totally had her, bro. I totally had her. Well, like lastly, all right. Real quick before I dismiss you, we get this. We know these, I'm not exaggerating to you. These actions, as they're listed in the book, those are literally the answers you will see.